Welcome, everyone, to Discussions with Dr. G. I'm Dr. G, still powered by coffee and sarcasm, and today we're wading into the heart of what makes community health nursing tick, or at least what's supposed to keep it ticking, even when the system feels like it's running on dial-up. I do want to start at the ground level, though. What are we actually talking about with all these terms? Public health, community health, population health, global health. If you're already mixing them up, trust me, you're in excellent company. My first semester teaching, I had an entire class of brand new nursing students thinking population health meant counting heads at a concert. Not quite. Here's the deal. Public health is the giant umbrella. Big, policy-driven, all about prevention and making sure society as a whole isn't, drinking lead and calling it lemonade? Community health zooms way in. Think of one neighborhood or one faith group or even a high school that really needs better cafeteria food. Your interventions are super local, sometimes even personal. Population health, sneakier. And I always forget the textbook phrasing, but basically it targets a group who shares a characteristic, like all the people with diabetes or all the kids under 5. And as for global health, now you're talking cross-border challenges, and let's be real, wrestling with political and economic inequities that make COVID response look like a warm-up act. What's the thread tying all these together? We talk about the client being the population or group, not just sweet Mrs. Jones on your med-surg floor. The goal is almost suspiciously simple. Promote health, prevent disease, and try to cut off trouble before it starts, aka upstream thinking. Now, if you've ever heard me try to teach upstream and downstream thinking, you know where this is going. I had this group of students, and every time I asked about interventions, it was like a race to grab rubber duckies out of a river. Everybody's scrambling to treat the problem after it's already floated downstream. Finally, I stopped class, grabbed a marker, drew a terrible river with even worse ducks. Why are we fishing ducks out of the river when the problem's up here at the waterfall where the ducks are falling in? It finally clicked. So think less about being a heroic duck rescuer and more about building a fence, prevention, and changing the environment. That's what real impact looks like. So once we get the definitions down, and don't be surprised, those pop up on the ATI and NCLEX way more than you would expect, the next question is, how do public health nurses actually do anything? That's where those classic 3 core functions come in. Assessment, policy development, assurance. If you can keep those straight, you're honestly halfway to sounding like you know what you're doing at a dinner party with other nurses. Assessment's all about collecting data, figuring out what problems are lurking in the community. Are asthma rates through the roof? Is access to healthy food a lost cause? Then there's policy development. This is where instead of just complaining, you actually get involved in advocating for change. Think lobbying for clean air, not just handing out inhalers. And the last pillar is assurance, making sure that the resources and programs you promise are actually happening and not just sitting somewhere on paper. You'll hear people talk about the 10 essential public health services. These got updated in 2021, but don't stress about memorizing every one. The big point, stuff like monitoring health, investigating hazards, literally disease detectives, educating your communities, making sure policies aren't just pretty words, and huge emphasis here, working toward equity and social justice. That brings us right to the gnarly question. How do we actually walk the talk of equity and social justice? It's not just giving everyone the same resources. It's giving people what they actually need, like handing out winter coats in Florida isn't helpful just because it looks fair on paper. And let me throw you a scenario. Say you're an occupational health nurse. Your company wants to promote safety, but management just cares about meeting the minimum OSHA box checking. How do you balance policy advocacy with the actual hands-on work of, I don't know, noticing the real-world stressors your workers are facing? That's what we mean when we talk about integrating assessment with advocacy. You get to be both detective and the squeaky wheel. Now, here's where it gets messier, because in community health, you're constantly juggling what's good for the group with ethical principles. We've got beneficence, to do good. Non-malfeasance, don't cause harm, which sounds simple, but let's say it's not. Justice is a big one. Make sure that the right resources go to the folks who actually need them most. Autonomy deserves a whole episode, but in brief, it's about letting communities make decisions for themselves, sometimes even when you think they're not making the right one. And then there's veracity and confidentiality, the good old tell the truth, protect sensitive info combo. Especially in community settings, like when you're collecting data on sensitive subjects, confidentiality is not just about locking your computer, it's about building trust. Informed consent, by the way, is not just a signature on a clipboard. It has to be real and ongoing, especially with community programs or screenings. Everyone should know what they're signing up for. Otherwise, you're venturing into some questionable territory, legally and morally. Let's clarify the levels of prevention, because trust me, the exam writers love to confuse you here. Primary prevention is your before the problem stuff, okay? Immunizations, health education, making nutritious snacks actually available. Secondary prevention, that's screening, catching stuff early. TB tests, vision screenings, blood pressure checks at the church picnic. Tertiary prevention. Now you're managing people with already established diseases. Think diabetes management classes, cardiac rehab, case management. And I have to laugh here. I remember prepping students for the big NCLEX, and we get the good old, is foot care primary or tertiary question? Okay. I swear, one more argument and I'd have to call campus security. But it's true. If your patient has wounds, it's tertiary. No wounds, it's primary. Same intervention, different level. That's why these scenarios matter. So keep those levels straight, grab your ethical compass, and don't forget, every time you prevent a ducky from falling in the river, you're making the world a little bit brighter for the whole community. See you next time.